Our topic is, we have come to discuss on antenatal care. So we are, in the next few minutes, we are going to stress just a few points that may be missed during our daily practice. Vasanthi madam, have you settled?
Yeah.
Shall we start?
Okay.
Madam, at what time would you like to start an antenatal care?
Good morning, everyone. Antenatal care does not start with a positive pregnancy test. It starts much earlier than that. A woman who is in perfect health, if she becomes pregnant, she will have a healthy pregnancy and a healthy mother and a healthy baby. For this, we have to do pre-pregnancy counseling. Whenever we meet with a woman who is likely to get pregnant, we have to counsel her. We can ask her when she is planning her first baby or the next baby. If she says it is, I'm doing my PhD, I would like to do that only after 3 years, then you give her oral contraceptives so that she will not get an unexpected pregnancy. But if she is telling you that I am planning a pregnancy, then you should take a detailed history of any diseases that she is having, do a clinical examination to rule out any hidden problems. Then you have to counsel her regarding reduction of weight if she is obese, if she is undernourished, you have to give nutrients. And if she is having some chronic disease, you have to investigate the disease and control the disease, especially SLA and all. You have to make the patient in remission, then only she should undertake a pregnancy. And if she is having diabetes or hypertension, you have to, or epilepsy, you have to make the drugs pregnancy friendly before she becomes pregnant. And if she is on some drugs, like if she is a smoker, alcoholic, or a drug user, you have to say a definite no to that.
Yes. And no smoking, no substance abuse.
Yes.
Yeah, we will have to advise her on that.
Yes.
And then immunization also.
Yes. If she is get a history of immunization status, and then if she is non-immune to any of the preventable diseases, immunize before she becomes pregnant.
Yes.
And last but not the least, tell her about the pre-pregnancy folic acid as well.
Madam. Yes, madam. Absolutely. Pre-pregnancy care and counseling has to be done, because the woman, as the woman enters her pregnancy in a healthy, optimum health when she is ready to face it. Yes, madam. Now, Chitra madam, now she has turned...
Can I just add one thing?
Yes, madam.
Okay, in some conditions, like we're seeing more of medical disorders complicating pregnancy. So if it's a heart disease and she's having rheumatic mitral stenosis, etc., we must see whether she requires a BMV before on.
Yes, madam. All medical disorders...
All that, we have to pay a lot of attention to that.
Yes, madam. Yes, madam. Now she has turned UPT positive and she has come to you, madam. So what all points you want to stress upon? Not all, everything. What points you want to stress upon?
Okay, like what madam said was the ideal condition, but very often we do not see patients like this. So they come to us like being a urine test positive. So in which case it's very, very important that you do a proper history, take a proper history. The history should include all the medical disorders that she had. Has she had any surgical interventions? Because now we see so many complicated cases, not like what we were doing earlier. So it's very important that we get a very, very detailed history. Medical disorders, what drugs, everything madam has said. The same thing must be continued during pregnancy. And then obstetric history should be in great detail. All the previous pregnancies, what were the complications that she had antenatally, complications that she had intranatally and postnatally also should be obtained. And examination will start when the patient walks in, because very often we see the patient lying on the table. We would not know whether she had a short limb or what her gait is. So it's very important that as the patient walks into her OPD, we should see her examination. And physical examination is something that is very, very important. We must pay a lot of attention to physical and clinical examination. See, this is a short video showing the physical examination. What was shown in this video is we forget to see the dental cavity. It's very important, apart from the pickle that all of us do, pallor, icterus, cyanosis, clubbing, etc. We must also see whether how her oral cavity is. So that's very important. And this is just showing you the peripheral pulses. We've had patients who've been diagnosed with trichinosis on the table when we took her up for a cesarean section. That should never happen. So always put your hand on the pulse and see whether it's felt and whether it's felt equally on all the 4 limbs. That is very, very important. After your physical examination, it's important to do a general examination of systems, cardiovascular system examination. We recently had a patient just a month ago. She's 34 weeks pregnant. She has gone to a practitioner with severe dyspnea, and they found that she had intractable. She was in pulmonary edema and she had a severe mitral stenosis. So that means the patient has been having regular antenatal checkup for 34 weeks and not seen at all. So that should never happen. So it's very important that we do a clinical examination the first visit. If you don't do it at that time, we're never going to do it, because every time it will be just doing, yes, we will do the next follow-up. We never pay attention to the first exam. So first examination should be the best examination.
Fully agree, madam. Nothing can replace a proper clinical examination. Thorough general and system examination is a must. Otherwise, we may miss many things, and that will come later and to worsen situation, worsen condition. So we have done all the general examination, taken all the history, general examination systems. Then we are doing investigations, blood grouping and RH typing, hemoglobin, and viral markers, and then now some screenings. Madam, regarding diabetes screening, there are so many screening guidelines are there. Vasanthi, madam, what guideline is to be followed when you address this audience?
Actually, India has become the diabetic capital, and many of our patients, about 25% of our antenatal patients are gestation diabetics or pre-gestation diabetics. So we recommend universal screening for all pregnant women, and this should start from the first trimester of pregnancy. And the method used is DIPSI method, that is Diabetes in Pregnancy Study Group India method. And the plasma glucose, the patient is given 75 gram of glucose at random at the first visit itself. So she need not come fasting. And then after 2 hours, you take a plasma glucose. And if the value is less than 120, it is considered as normal. If it is 120 to 139, it is gestational glucose intolerance. More than 140 but less than 200, it is gestational diabetes. And if the value at 2 hours is more than 200, it is pre-existing diabetes.
Madam, can you just enlighten us about thyroid screening also? Is it needed for
No, I
all
would like
women?
to add something here.
Yes,
if the first visit it is negative, it has to be repeated in the second trimester.
Madam.
If it is negative again in the third trimester,
Yes.
because that is the time the glucose intolerance becomes more and more
After
severe.
24 weeks and in third trimester.
Okay.
Yes, madam.
Doctor, see, the other thing that we can do in the first trimester for screening for diabetes, apart from OGDT, would be to do a HbA1c, because in that first trimester, we're trying to find out whether the person has had a pre-existing diabetes. So a fasting blood sugar and a HbA1c more than 6.5 or an FP is more than 126 is also accepted as a diabetes mellitus called.
Okay, madam. Thank you, madam. Madam Vasanthi, madam, regarding
Thyroid screening. Different societies give different opinion about the screening for thyroid diseases in pregnancy. But as we are seeing more and more of subclinical hypothyroidism in pregnancy, it is better to offer universal thyroid screening for our pregnant women. It should be done in the first trimester and by a TSH examination. If the TSH has, that is thyroid stimulating hormone, it has different values in different trimesters. First trimester, the cutoff is 2.5. Second and third trimester, it is 3. If the values are more than 3, or in the second and third trimester, or more than 2.5 in the first trimester, it is better to do a TPO antibody as well as a free T4, and then treat the patient accordingly.
Yes, madam. Now we have screened diabetes for thyroid disorders. Now, madam, what is to be done to screen for preeclampsia? Chitra, madam.
Now, preeclampsia, like we said, we see more and more patients with hypertensive disorders complicated pregnancy. So it's very, very important that you see for preeclampsia. One is the gestational score, which everybody should have it on the table and then screen for the patients. The other one is there are 1 or 2 things that you can do for screening. The most important is when you do an NT scan around the 11th to the 13th week, as a routine, everybody should know how to do a uterine Doppler studies. So this is a small picture showing a uterine artery Doppler, and it says that you must measure what is the uterine artery Doppler, what's the pulse LPI index. If it is more than 95th percentile, that means a particular person is more prone to develop preeclampsia or develop a baby with FCR. So that is one thing which anybody could do. In fact, many gynecologists would be doing, but if the scan is being done by a radiologist, they may not do the PI, so may specifically ask for it. The second thing which has been recommended by the Fetal Medicine Foundation is they have a score. where certain general characteristics of the patient is taken into consideration, like what is the weight of the patient, what is the height of the patient, does she have any pre-existing disease like chronic hypertension, diabetes, SLE, or she's known diabetic. And these demographics, along with mean arterial pressure, and then they take the uterine artery PI and biochemical markers like PAPA or PLGF. So they take this and then they put a score. So this is a chart which is showing, this is one of the patients who had this chart. Can you show me the next slide? And here the scoring is there, which says it is a low risk score. If the score is less than 1 in 100, it says the person is having a low risk for developing preeclampsia. Now this is very important, it should be done at the 12th week, because if the risk is high, then you have to start the patient on aspirin 150 milligrams per day.
Okay.
Now there's another simplified chart. I do not know whether you've added the chart.
Which one, madam?
Okay, the next, okay, doesn't matter.
Yes, madam. So, those those women who are at high risk, we'll start our own aspirin, isn't it, madam? Then now we have screened for diabetes, thyroid, preeclampsia, but one should not forget about mental health. Issues like mental health should not be forgotten, and we should include screening for that. The history should be taken sensitively and find out those women who are having mental health issues, and screening for women, those who are at risk of developing mental health problems during pregnancy and postpartum. So we have to screen for that and offer help and do appropriate referral. And also like violence against women. It's about 60 to 65% according to the community study that has been conducted in India. So we have to take that history sensitively, and also in private, we have to talk to her alone and take that history, encourage them to talk about it and offer help. There are systems in place like Bhumika. In Kerala, we have got Bhumika by NHM. There will be similar organizations that will take care of that issues. That's by NHM. So there are systems in place, and we have to offer help for that. Now the screening is over, then we have done all the investigations. Now what is the take on ultrasound scan, madam? In the first visit, is it necessary? And what is the policy on ultrasound?
Ultrasonography is a must in pregnancy. And most of our patients come with a positive pregnancy test and say that I am pregnant. And many of them will have symptoms like lower abdominal pain, unilateral pain, spotting, discharge, and so on and so forth. Many complaints in the first trimester. If the patient has any complaints, it is better to do an early pregnancy scan when she comes between 6 and 7 weeks, so that it will tell you whether it is an intrauterine pregnancy or and confirm the viability as well.
Yes.
So the problems are excluded in the first trimester.
Yes.
But the two must scans are NT scan at 12 weeks and anomaly scan at 20 weeks.
Yes.
Okay. And 30 to 34 weeks, you can offer a growth scan which may help you to diagnose late onset IUGR.
Okay, madam. Okay, madam. Thank you, madam. Now, most women will have this NT scan.
But Dr. Sati, one minute.
Yes, madam.
See, like madam said, 30 to 32 weeks. Because nowadays we tend to see a lot of cases with late onset FGR also. Supposing you do a scan at 32 weeks, you must, if it's possible, repeat one again at 36 weeks.
At 36 weeks. Okay, ma'am.
So it's
if possible.
If it's possible.
If it is possible, yeah. And if it, okay, ma'am. Okay, ma'am. So most women will get ultrasound scans done, especially the NTs and all. So, madam, do we need to do double markers and all those screening in the first? I mean, in that at that time, is it necessary for all?
Okay. Now, the very idea of your NT scan is just not dating the pregnancy. It has a lot of importance in the first trimester. So, it's for screening for aneuploidy. And one of the most important aneuploidies that we come across is Down syndrome. The other two aneuploidies like Pattus and Edwards might get aborted. So, initially to start off with, this double marker screening was done only for individuals who were elderly, more than 35 years, because we thought that Down syndrome was more common in these elderly individuals. But however, we should remember that the bulk of people getting pregnant are in the reproductive age group, it is 20 to 30 years. And the number of patients having Down syndrome is more in this group rather than that group. So it has been said that universally for everybody, it will be preferable to do a screening for Down syndrome. One of the first screening would be your plain NT alone, which has a detection rate of 70%. So along with this, if you combine it with a double screen, your FTS, first trimester screening, which involves your PAPA and beta HCG, if that is being done, then it will give you, if that test is negative, it will give you a detection rate of 92%. So every person must have a NT with a double marker screening is what I feel.
Okay, madam. Thank you for making that clear. Now she has coming for regular antenatal checkup, and in the first visit itself, after taking history and doing all the investigation, we have to document it properly in a comprehensive antenatal card. So in the first page, we have got all the details, history, and in the last page, there will be space for medications and also investigations, including ultrasound. In the middle page, we have got certain parameters that can be entered to enter the findings that we do in antenatal regular and subsequent visits. Vasanthi madam, what is to be done like in subsequent visit? Actually, what is to be stressed upon? That's all. What is to be stressed upon during the antenatal visits?
Actually, even though we have ultrasound at every obstetric clinic, it is better to keep up your examination skills. Earlier we used to do the abdominal fundal growth measurement by this method, and now this is where more subjective. Now we are doing the objective method of measuring with a measuring tape. From the you identify the symphysis pubis, you identify the fundus, and then from the symphysis pubis to the fundus, using the measuring tape, you put the inside outside, and then pinch at the fundus, and then turn this tape. Then you can see the measurement in centimeters. This will take away the observer bias. And this measurement has to be plotted on a gravidogram like this. The gravidogram is nothing but a chart showing gestational age in weeks in the x-axis and fundal height in centimeters in the y-axis. It corresponds, actually in centimeters, it corresponds to the gestational age. Okay. So at 20 weeks, it is 20 centimeters. So if it is less than the 10th centile in the chart or more than the 90th centile, then you have to exclude intrauterine growth restriction or large for gestational age baby. You don't get worried about the gravidogram. It is better to include the gravidogram in your antenatal chart, but if it is not there, the variability in the fundal height is plus or minus 2 centimeters is taken as normal. But if it is less than 3 centimeters, minus 3 centimeters, or more than plus 3 centimeters, then you have to rule out intrauterine growth restriction or large for gestational age baby.
Okay, madam. Thank you, madam. So that is regarding the record. And what is to be, can you just briefly tell about the iron, calcium, what the different preparations are available, what is to be given for her?
Actually, most of our patients do require supplementation during pregnancy, and iron, government has prescribed iron or is supplying iron for all our pregnant women, 100 milligram of elemental iron plus 500 microgram of folic acid. That is the Government of India standard, 100 tablets to start from 16 weeks of pregnancy. And folic acid, I have already mentioned, 5 milligram pre-pregnancy, and it has to be continued through pregnancy. Through the first trimester of pregnancy. Calcium, the requirement is 1 gram, that is 1000 milligram per day. Vitamin D, when we started measuring vitamin D in all our women over the past 10 years, we found that most of our women are vitamin D deficient. So vitamin D supplementation is also essential in pregnancy. 400 microgram for all patients. The 800 international units. 800 international units for pregnancies likely to develop severe preeclampsia, and 1000 microgram for women who are likely to develop severe vitamin D deficiency. Like people who don't get out of the house or people who always fully cover themselves when they go out. Such patients, you have to give 1000 international units.
Okay, ma'am.
One word about iron. Now there's a lot of papers which is coming up which is saying about intermittent iron therapy. If a hemoglobin is very good, then it's possible that you give iron intermittently. Every alternate day is also good enough.
Okay, ma'am. So regarding vaccination, what is to be given? TT, TD, Tdap, all are available. What is to be given?
Now the government says only TD should be given, and then one TD. Then the ACOG recommends at 30 weeks you give Tdap, and then during the influenza season you give an influenza vaccine. Then there are other apart from this, there are other vaccines that can be recommended in high-risk cases, like where the person has sickle cell disease or HIV, which would be your meningococcal and pneumococcal vaccine. With that we forget.
Okay. Okay, ma'am. So a lot of has been talked about in antenatal class. So what is, just briefly in a few seconds.
No antenatal care is complete without antenatal classes.
Yes, madam.
Classes can be conducted twice during their pregnancy. First in the first half of pregnancy, the next in the second half of pregnancy. First half of pregnancy, you tell everything about the antenatal care, and then the second half of pregnancy about labor and delivery, postpartum care and contraception. And at this time, you have to tell them about the danger signals so that if they encounter any of the danger signals,
we have
they
to
can
report
report to us.
And also a delivery plan can also be made. So to conclude, so in the last few minutes we have been rushing through and we had just actually highlights. That's like you see highlights. That is only few points that we thought that needs to be stressed upon, because antenatal care itself is a vast topic. So a few points that is we wanted to put forward, that care ideally starts preconceptionally and screening of risk factors has to be done, and nothing can replace a clinical examination and has to be documented. Complete comprehensive documentation has to be there in an antenatal card, and medications, clarity about medications, and to stress the importance of antenatal class. Thank you very much. Thank you, Chitra madam and Vasanthi madam, for actually you have been very